in the treatment of patients with CML and chronic phase, our major goal is to do just that, prevent progressions. We know that progression to accelerated phase and blast crisis is associated with a much inferior survival than patients who remain in chronic phase. And we know that with nilotinib and dasatinib, there were fewer progressions in the first 2 and 3 years compared with imatinib. For me, that's the most important reason to use a second-generation drug as first-line therapy. One other additional consideration now is that in the 2013 version of the NCCN guidelines for CML management, at 3 months, patients are expected to be in to have a molecular response defined as a 1 log reduction in the BCR ABL to ABL ratio. In both the DECISION trial and the INEST-ND trial, it was shown that the likelihood of achieving that milestone was higher, greater, with the second-generation drugs, dasatinib and nilotinib, compared to imatinib, which means that if you are starting with a second-generation drug, you're less likely to be put in the position where you're thinking about making a change in therapy early on in the treatment of your patients. In terms of tolerability, I think the data now shows that these drugs have different side effect profiles, but they are all consistent with prolonged therapy in patients with CML and chronic phase.
Okay.